Hello, I am Bizrah, consultant ENT facial plastic surgeon. I published my textbook on rhinoplasty, facial plastic surgery in 2002. The book has more than 500 pages and 1,000 illustrations. The textbook was forwarded by the presidents of the American and European Academies of Facial Plastic Surgery and was distributed worldwide. I hope you find these videos are very interesting. It's designed mainly for surgeons, plastic surgeons and ENT and facial plastic surgeons. It's professional and educational. It presents my approach, my school, the Bizrah School of Rhinoplasty. You are most welcome and I hope you find it very interesting. This is an interesting case of wide tip and underprojected tip. The tip actually look like as if it is the breast against the glass of the window. So you have the tip like the boxy or trapezoid tip, and you see now how here the tip is pushed backward as if it is pushed by pressing against the glass, and with short columella, under projected tip, very wide tip. So our plan is to do now mainly Tip-12, which would include oblique modified dome division, columellar strut, tip graft, the midline structure of medial cura, intermediate cura, and the columellar strut and tip graft. Also maybe bilateral cura overlay technique endonasally. Okay, I hope you enjoy the procedure. Thank you. Procedure now, so we start with an incision near the caudal end, just behind the caudal end of the septum, because we might need to do the tongue in groove technique in this case. Usually I go 1 centimeter behind the caudal end of the septum, but when there is a possibility of using the caudal tongue in groove, I go just at the septum. And as you see now, I just went straight to the right plane, so my dissection runs very smoothly, and within few seconds we elevated the left perichondral flap. Again, now we make incise the cartilage, and we'll go to the right side and elevate the right perichondral flap. Okay, and that's it. Now the cartilage in the middle, both flaps being elevated within maybe 1 minute, because we prepared the nose very nicely and we are working on the right plane. Now with Ballinger knife, I will just get a cartilage which I'm going to use as columellar strut and maybe tip graft. You see? Okay. Just put the flaps back now. And with sharp scissors, I would prepare the caudal septum from the other side to go to the pocket in between the two medial cura later on for the tongue in groove technique. Okay. Now we will do the transcartilaginous incision at level of midline of Keffer-Keter mid-Keffer-Keter and towards the midline, almost less than 1 centimeter. So we try mainly to work on the midline in this area, not to go to the alar side wall. Again, on the other side, you see we are just very quite medially and towards the midline, less than 1 centimeter incision, and then with sharp scissors. See? The operation under local sedation, and then undermining the dorsum gently. You don't have to do much undermining in this case. And you see this fullness here, the supra-alar fullness in this side is contribution of 2 factors: the curvature of the upper lateral crus, the curvature of the upper lateral cartilage and the lateral crus. So now we'll first deal with this is the curved part, of the apparatus cross, as you see now there. You just get the mucosa down and remove this curvature with some soft tissue there. Soft tissue, as you see. A lot of soft tissue there. And you see as the apparatus cartilage is still fully intact and with full connection to the dorsum septum. Again, you see now the difference. This one went slightly in, this one is still bulging there. We'll go to the other side now. Again, this is the curvature of the apparatus cartilage, and we just trim it. Preserving the mucosa. As you see, the mucosa is fully preserved there. Remove some of the soft tissue. Okay. So now, okay. Next step now, we sharp double hook and go into the tip defining bone. This is the tip defining bone there. This is the junction between intermediate cusp and lateral cusp. The principle of our technique is to preserve fully the lateral. This is the lateral cusp, is to be preserved fully. No marginal incision, no marginal incision, no exposure. And will not borrow any part of the lateral cusp, will not steal any part of the lateral cusp. So we go, this is the intermediate cusp, and this is the junction, tip defining bone. We go medially on the intermediate cusp, and that's it. You see, we preserve fully the lateral cusp. Again, on the other side, tip defining point, and again we go medially, and fully, as you see, preserve the lateral cusp is fully preserved, as you see. No marginal incision, no exposure. Now we deliver the two intermediate crura to one side. We preserve the rim cartilage, as you said, to avoid notching. Again, here you see we fully preserve the rim cartilage there to avoid notching. And now both intermediate crura are coming to one side, delivered to one side with part of the medial crura, as you see. Very nice, very clean. So we fully preserve the lateral cusp. No marginal incision, no exposure, no steal, and nothing to borrow from the lateral cusp. Okay, that will significantly reduce the post-operative problem for rhinoplasty, as you are mainly working in the midline. So you just a bucket now between the two medial crura. Okay, and we go to our graft now, and we obtain the graft, and then a columnar strut. So that's the columnar strut now. So we are creating a strong structure in the midline to help us with tip projection, tip elevation, tip definition, tip narrowing, tip refinement, and this will stretch the columella and treat any retracted columella or hanging columella and short columella. عم بيطلع عندك الضوء اوكي مع مين حاجه. So we're creating this strong structure in the midline of medial intermediate crura supported by columnar strut, and now we'll add also a tip graft. We'll add a tip graft now. You see now, we just make a bucket again along the caudal end of the medial crura down the way, and then we'll insert the tip graft. Okay, so that we got now a very strong structure in the midline of tip graft, columnar strut, medial crura and intermediate crura. This should give us adequate tip support and tip projection and rotation, and compensate for the loss of tip support caused by our incisions and excisions. But as you have seen now, we did not excise much. Nothing been excised from the entire class, so it's a technique of incisions more than excision. It's an incisional technique with refinement with rearrangement of the cartilage in order to achieve the desired results. Now, give a sharp scissor. I always try to keep the area nice and clean so you can see. Now just arrange for the bucket for the tongue in the groove technique for the caudal septum to go in between the medial crura, creating the bucket. Okay, so we're getting the caudal septum the two medial crura over the caudal septum in the midline. Yeah, wait, give me the graph once more. I'm going to consider another double tip graph because the patient has got really under projected tip, and the tip was, look, if it is the breast or breast against the glass, so I'm going to add additional tip graph there to give me nice contour for the tip area. This will achieve better result because the patient has got slightly thicker skin and under projected tip. And as I said, the tip looks like if it is breast against the glass. So we need to have a consider double tip graft. So we put the structure back now to the midline, to its place. See, we already had a very nice, as you see now, if we go to the side view, very nice tip projection, compared to before. The tip before was doing like this. Now we got all this nice tip projection. Nicely stretched columella, nice nasolabial angle, nice double break. And now what we'll do, we'll just see if we tongue in the groove. Yeah, that's good, okay. We need to get this caudal septum, as you see here, the caudal septum in between the two medial crura. Okay, give me the we'll remove the excess tissue. Cut it nicely. Excess tissue removed, redundant tissue. Make sure the bucket is okay, adequate. So this one now is much better. They give me my Kimball. I need to mark with my suture. Okay, straight needle now. No need for my nasal back, no much bleeding. The procedure under local with sedation. The patient nicely tolerating the procedure. Clean for me, clean. Okay. So we start high up. شايف انت؟ High up on the septum. تعال شوي. And back to the columella, to the middle crura, and then back to the septum again. back to the medial cura. My finger makes sure that the caudal septum is going in the middle between the two medial cura. Okay. And do not really squeeze too much. You just want the caudal septum to go in between the two medial cura, the tongue and groove technique. You see now at the profile. Look at the profile now. And just compare with this profile here. Compare with this profile. You see the profile? The profile there. And go back and see now the big difference. The big difference now. The big difference is the profile. Haven't finished yet. We still need to one more suture just for more safety. One more septocolumella suture down here. Just to be on the safe side. One more down there to be on the safe side. Again, with your finger, make sure the caudal septum is in the right place, in between the two medial cura. You see how we preserved the structure and the anatomy of that cast there. Very nice. Okay. Let me try double hook. Still little bulge in there. Actually, in normal situation I wouldn't bother because it looks very nice, but this patient was mainly concerned about the bulge. He said reduce this bulge here. So I'm going to consider now the lateral cura overlay technique. And again, I said I would not excise any part of the lateral cast. So no marginal incision, no exposure. We just go, give me my pen. We go mid halfway of the lateral cast, halfway there. Okay. And then with sharp scissors, under the skin. Hold it, stretch it. Hold and stretch. You see now, it's under the vestibular skin, about 1 centimeter, and then turn your, leave it now. Turn your scissor 90 degrees and cut. So both sides are overlapping now, as you see. Just remove this small sharp edge, refresh this sharp edge, that's it. So they overlap each other now, so we reduce, and you see reduce the fullness here. So the fullness here disappears, we still have some fullness there, we are going to deal with it now. So right lateral cura overlay technique indonesially, now left lateral cura overlay technique indonesially. You see that cast very nice piece left in place, marking bend to support the alar sidewards, and then it's halfway again with sharp scissor. About 1 centimeter under the skin, and then turn your scissor 90 degrees and cut. And you see now it's overlapping. I just remove this sharp edge there. So we already, now this is the maximum we can do. You see this now, much better, more definition, more refinement of the tip. The procedure endonasally, working mainly on the midline. It's very nice. We did now a lot of procedures for this patient. Tip-blasty, tongue and groove technique, bilateral cooler overlay technique. Endonasally, now we are going to define these to divide the frenulum and divide the septonasine muscle. Okay. Alright, so this will give us more rotation and reduce the tension of the muscle, and this patient, when she laughs or talks, the patient become wider. This will reduce this effect on the patient. So we have done very nice, very clean surgery, working mainly on the midline. We preserve the structure, we preserve the anatomy, preserving the lateral cross, mainly because in my opinion that most of the problems related to rhinoplasty are related to the wound healing, contracture and scarring along the alar side wall, which are out of the hand of the surgeon. So when you preserve the lateral cross, no marginal incision and no exposure, and no, you don't steal any part of that cross, then you definitely left with very excellent support of the alar side wall and reduce the post-operative problem. So the operation being done under local with sedation. How many minutes now?
22 minutes, 56 seconds.
Okay. So, yeah. I mean, now less than 25 minutes, we should have done, finished the procedure. So, that's it now, finished. Done, everything been done. Okay, let us look now at the photograph and compare the result again. You see now the tip, how the tip was extremely wide, and the base, you see the boxy tip, and the side, the profile, the underprojected tip, the short columella, and look now what we achieved in less than 25 minutes. Very nice tip projection, tip elevation, tip rotation, tip narrowing, tip refinement, with very nice nails symmetry, and more tip definition, narrowing, refinement, and very straight nails. It's all been done under local with sedation, operation less than 30 minutes, patient which will be discharged home today, same day surgery. This is Bizrah from BMC in Dubai and London. Thank you very much.